would like to introduce Steve Kemble, who for most of us needs no introduction. And he is a semi-retired psychiatrist in Hawaii. Is the chair of the policy work group for one-payer states and the policy chair for PNHP. Was president of the Hawaiian Medical Association, and I think you're still on the Hawaiian Health Authority Board. Or
it's inactive, but since they never elected a replacement for me, technically I am, but we've been sidelined by the state.
But you just got invited to another board, as I understand.
Yes.
Okay, that's good. Well, go ahead. You can tell us what your views are on value-based payment systems and other alternative systems.
Okay, I'm going to just briefly say what value-based payment means, what's its rationale, what are its incentives, and what are the results. So value-based payment is upfront payment for care through capitation or bundled payments, and it also includes pay for performance or pay for quality using financial carrots and sticks to try to supposedly improve healthcare. And all of these involve shifting insurance risk onto either a financial middleman or onto the providers of care. And by insurance risk means there is variable cost year to year in insurance. There'll be an epidemic one year and not the next, or there'll be a sudden jump in pharmaceutical costs one year. And so if you're a government agency like Medicare and Medicaid, and you're just paying the claims as they come in, which means you have the risk, you have to deal with the ups and downs of the cost year to year. Whereas if you contract with a middleman on a per person per month basis, then they have the risk because they've been paid up front. And the more they spend on care, the less they get to keep, and the less they spend on care, the more they get to keep. So that's shifting insurance risk. And if you have pay for outcomes or pay for quality or things like that, there too, you're on the financial hook for whether or not your population costs more or less in a given year. So all those things involve shifting insurance risk off of government onto some either middleman like an insurance company or ACO plan or something like that, or else onto doctors and hospitals themselves. So why do this? So the rationale offered is that fee-for-service allegedly induces overutilization of care because the more care you deliver, the more you make. And so therefore we have to get rid of fee-for-service, and with value-based payment, if you're paid up front for care, then you have an incentive not to do unnecessary care, to restrict care, and that this is going to reverse the incentive of fee-for-service to overuse care. The problem with this is that, and presumably it would deliver only care that has value, so that's why it's called value-based payment. The problem with this is that there was never good evidence that our healthcare costs are excessive due to fee-for-service. There are a lot of other countries that use fee-for-service that spend half what we do on healthcare. And in Hawaii, for example, before the Affordable Care Act, when everyone is paid for fee-for-service, our per capita Medicare costs were the lowest in the country, and we had the broadest coverage and among the lowest health insurance premiums in the country, all paid for fee-for-service. And since we've been moving to value-based payment, our health insurance premiums have doubled. So the idea that our cost problems are due to fee-for-service is really difficult to justify when you look at some fundamental facts like that. So let's look at the incentives that are supposedly fee-for-service is an incentive to overuse care. And there are some examples where that does happen. I'm not saying it doesn't happen at all, but it happens in other countries too, and it doesn't explain the difference in cost. But so if fee-for-service supposedly incentivizes overuse of care, what does capitation incentivize? Because no one in the policy committee, or very few people, are really looking at this. They just assume that fee-for-service is a problem and value-based payment is a solution, and they don't even question their assumptions. So what are the incentives that are inherent to capitation? First of all, if you're paid a fixed amount up front and you're at risk so that the more you spend, the less you get to keep, and the other way around, if that's the way it works, then you make more money by capturing healthy people and avoiding sick people. So you have an incentive to cherry pick your risk pool. And this turned out to be, when they capitated Medicare Advantage plans back in the 90s, this became an immediate problem that the plans were marketing to the healthy and avoiding the sick. So this is an incentive that's fundamental to capitation. So the attempt to counter that incentive is risk adjustment, where you try to estimate the likely cost of an individual or a group, and for the ones who are going to be more expensive, you pay the capitated plan more, and for the healthier ones, you pay them less. And so that you would then reverse the incentive to cherry pick the healthy and lemon drop the sick. The problem is that there is no good way to estimate the cost for individuals. The most accurate way would be to take prior year spending, but if you did that, the incentive would be to spend as much as possible one year so that you would get a higher capitation rate the next year, which would completely defeat the idea that this is going to be a cost control mechanism. So what they use is categories, and they started out with demographic categories, race, sex, zip code, things like that, and that managed to predict maybe 1% of cost, because there's way too much variability within all those categories for a categorical risk adjuster to predict individual risk. And so then they added diagnoses, which improved the accuracy of the risk adjustment formula to about 11 or 12%. But the problem there is that there's still way too much variability within all those categories, and 11 or 12% is nowhere near accurate enough to deter cherry picking and lemon dropping. So risk adjustment has never worked for its stated purpose, but it tied diagnosis to payment and opened the door to a brand new way to exploit payment, which is upcoding. You try to find as many diagnoses as you can and make them sound as severe as you can. And the more you can do that, the more you get paid by the risk adjustment formula. So risk adjustment really turns out to be a door to upcoding rather than a way to correct for the incentive to cherry pick and lemon drop. And so now you have both problems. The third incentive that's inherent to capitation, if you're paid a fixed amount up front, the less care you deliver, the more money you make. So there's an incentive to skimp on care. And that incentive applies to necessary care just as much as unnecessary care. So there's a real problem with just trying not to do anything for people, which would be a very bad thing for the health of the country. It is. So to try to counter that incentive, CMS and insurance companies implemented pay for outcomes or pay for quality, so that they're saying, since we're going to pay you for your outcomes and quality, then if you try to skimp too much, you're not going to get those extra payments. But the quality metrics are, quality in healthcare is extremely complex and difficult to measure. So they measure whatever is easy to measure, and those metrics are easy to game. They have very little to do with actual quality, and they become just another way for the insurance industry to game the system. If you try to apply capitation at the level of a primary care doctor, you introduce the same incentives, the incentive to skimp on care, the incentive to cherry pick and lemon drop your risk pool, the incentive to upcode. All those things apply whether it's an insurance company or an individual primary care doctor. And again, these incentives are fundamental to capitation, but they're not widely appreciated in the health policy community. The last incentive is that capitation is a portal for profiteering in healthcare, because if you're paid up front, you have an opportunity to profit by either skimping on care or by gaming the payment system. Whereas if you're paid an administrative contract to process claims, there isn't much opportunity for profit in that. So capitation is a door to profiteering. And the reason that fee-for-service has been demonized is not because there was ever any evidence that it's a source of our high cost of healthcare. It's because the insurance company needed to demonize fee-for-service in order to get their foot in the door with capitation and try to profit off of healthcare. And this is what I think is the real incentive behind value-based payment. It's a portal for profiteering. So Our next project on the PNHP policy committee is, we just did a report on the ways that Medicare Advantage plans game the payment system to be overpaid by anywhere from a quarter to a third of what they get paid as overpayments compared to traditional Medicare. And this is because of the capturing a healthy risk pool, upcoding, skimping on care, all the things I just said. They exploit all of these to jack up their own payments compared to traditional Medicare. So we looked at the fiscal complications of these perverse incentives. Now we want to look at how they affect doctors, hospitals, and patients. And for doctors, you have the capitated plans generally have limited networks. And the reason they do that is the more limited your network is, the more you scare off sick people, and healthy people don't know that it's limited or don't care yet because they're not sick. And they're attracted by extra benefits and lower premiums. So this is a way to cherry pick and lemon drop your risk pool. But if a plan has a narrow network and you're a physician in that plan and your patient needs a specialist, it's not going to be available. If they develop cancer and need a hospital that specializes in cancer treatment, it's not going to be available. So it really interferes with your ability to arrange the best care for your patients. Capitated plans impose all kinds of restrictions on care, prior authorizations, restricted formularies, things like that. So you have to fight with the plan all the time to get your patients the care that they need. And if the plan requires a prior authorization for a particular drug and it's a chronic condition that's not going to change or go away, they still require you to get a prior authorization every year. And so this really adds administrative burdens to doctors and hospitals. Delayed payment, denied payment are much more frequent with capitated plans than with direct payment by Medicare or Medicaid to doctors and hospitals. The data demands of risk adjustment and quality improvement require very detailed data on diagnosis and procedure coding, much more so than fee-for-service payment. And this also adds more administrative burdens and costs both to the providers of care and to the plan. And doctors are pressured by Medicare Advantage plans. And if the doctor's practice has been bought up by private equity, it's pressured by them because they're also running a Medicare Advantage plan and an ACO REACH plan that's paid with capitation. So they really pressure their doctors to upcode, to avoid referrals out of network, even if it's something the patient needs. And all of this adds up to doctors being forced to cater to the financial goals of the capitated entity or their own capitation if they're capitated at the expense of the patient. This leads to demoralization, moral injury, and burnout, which are rampant problems in US healthcare. For the patients, a lot of these things have a flip side on the patient. You have narrow networks. You can't get the specialist you need. Your doctor is going to be undermining your care because they're paid more if they do so, which means the loss of trust in their physician. And there's also a huge problem with false and deceptive advertising. Medicare Advantage plans advertise low premiums and extra benefits, but they don't tell you the network is limited. They don't tell you they're going to deny care much more often. They don't tell you they do all kinds of prior authorizations and formulary restrictions. They don't tell you any of that. So there's some interest in the Senate right now in reining in false advertising in Medicare Advantage. So that's a brief summary of what value-based payment means and what I think its real implications are. Any questions?
Wow. Thanks, Steve. Yeah, please send your questions. How about the chat? Anybody in the chat? Oh, Jan Phillips, raise your hand.
Hi, Dr. Kemble. Thank you so much for your presentation. I really appreciated that because, of course, value-based care sounds so wonderful. I'm not sure exactly where I've read this, but they were talking about a capitation system where it is bundled with a salary for the physician, and the money in the capitation just keeps revolving for patient use only, whatever the patient needs. And so it's not an incentive for a doctor to restrict the, the services, the labs, whatever, the diagnoses he or she is talking about, because they're not going to reap the benefits from leftover money, so to speak.
Mhm.
And also, my question is, how do you measure quality of care, or how is it typically measured?
With regard to the first question, let's see. What was the first question again?
I've read about a system of capitation
Oh,
where
yes.
it just revolves.
Yes,
Patient care only.
partial capitation. There are proposals to pay doctors a partial capitation payment to cover the cost of chronic care, with the rest of their pay either coming from fee for service or salary, which I don't think are so bad. Because if all of your pay depends on your risk pool or your outcomes, then all those perverse incentives come into play. But if the bulk of it comes from something that doesn't involve risk shifting, which would be either fee for service or salaries, and you only have a limited capitation to cover all the extra stuff you have to do to coordinate care or to deal with patients with chronic conditions that are going to be ongoing, then I think that can be a reasonable way to go that doesn't have all the perverse incentives. So I do think there is room for that. But I do think that when you get to total capitation, especially if it's capitation for the total cost of care, then all the perverse incentives come into play.
Yeah, agreed.
And your second question was?
How do you measure the quality?
Oh, measuring quality. The metrics usually have to do with things that are easy to measure. And this, you might be capturing 1 or 2% of what doctors do for their patients. So it's just that most of it is much too complex to be measured easily. So you can get a project where you're measuring some particular aspect of healthcare for the purpose of improving it. That's a reasonable thing to do. But if you're trying to look at overall quality, there is no way to measure that in a reasonable way that's not going to be so narrow as to be almost meaningless and also easily gained. It's easy to teach to the test.
And one last one, if I may. Oh gosh, I'm just blanking on it. Oh, fee for service also seems to really muck up the understanding of prices, price transparency, to be able to add all the things into, and I guess that's more hospital related rather than a doctor's office. But boy, with what hospitals are supposed to show for price transparency doesn't come close to the actual cost, and even figuring the Medicare rates. So is fee for service the one that's mucking that up, unless, if it were bundled?
That's a great question. And I think that fee for service as we know it in the US is very messed up.
Okay.
There are much better ways to do fee for service than what we do. I think hospitals should be completely taken off fee for service because that's where most of the abuse occurs. I think hospitals should be paid with global operating budgets based on the cost of operations. That includes the salaries for all their employed doctors, nurses, physical therapists, maintenance people, everybody that they need to employ. Give them a budget, include the salaries, and let them just pay people to do what they need to do, and don't do fee for service at all for hospitals. No one has shown that there is significant abuse of fee for service in primary care, which is the main place it's getting pushed onto providers of care as primary care doctors. So that's the problem, is the hospitals, not with the primary care doctors. I do think there is some abuse with certain procedural specialists, and that gets amplified if they're owned by a hospital or by a private equity company that's pushing them to do all these, to overuse care, to schedule unnecessary procedures, things like that. It was less of a problem when everybody was in independent practice and kind of accountable to the community. But I do think there are abuses, and most of them occur from the corporatization of healthcare.